Assalamu alaikum, colleagues. Dr. Jamshed, thank you for extending this invitation. I have few disclosures. Number one, some of the material presented in this talk is published and or in the press. Number two, I'm not the expert on this subject. Perhaps some of the high centers, high volume centers in Pakistan and abroad have much bigger experience than us anyhow. But I would like to share our experience regarding conjoined twins and university hospital. Birth of a conjoined twin is fascinating, not only for the medical fraternity, but also the public. Press, both electronic and press media, and these cases are often highlighted in the media very well. The incidence of this abnormality is reported in books as 1 in 50,000, but about 60% come in utero because of associated anomaly. And another big percentage die immediately after birth, especially in Pakistan, where antenatal and postnatal care is not up to the mark. We have the highest infant mortality in the region. While dealing with these patients, what I came across, those who survive even after this, they die waiting for surgery. They may not be referred appropriately or cared appropriately. This is, I would call, a hidden mortality in conjoined twin in Pakistan. If you hit the PubMed with conjoined twin term, there are about more than 2,000 publications, about 1,500 are full text. Most are the case reports and few series, but topic ranging from the history, life of patients who were born as a conjoined twin. Very interesting reading, but I'm not going into detail on these. I think most of you have read, and some of it, this history is in our textbook as well. The first successful operation was 1689 by a Swiss surgeon. And that is fascinating. If you go into details of this case, these two patients were just joined by a bridge of skin, and they were separated by putting a clamp. How easy was the life those days? To my best knowledge, the first successful separation of conjoined twin was performed by our Professor Naeem Khan in Islamabad, in 1996. Now that's what I know. Maybe others have done at other centers, which I don't know. After these 2,000 publications, these are about the 800 cases which are reported with this abnormality. And attempt at separation has been just in 250 cases. This has, the number of cases, reporting of these cases has increased after 1990, and so are the attempts of separation, which I ascribe it to the media highlights and advances in surgical procedures, intensive care, and maybe anesthesia. If you examine these papers very carefully, the survival is more in patients who have been separated after 1990. There are few reported series. If you look at them carefully, the four things come to your mind. One, not all the patients who present to the hospital for evaluation or for operation. Many are not fit to be undergo an operation. Operation done in an emergency has a poor survival. Planned procedure has a better survival. About 50% of these cases, because associated congenital anomalies require 3 to 4 surgeries after the separation surgery. And 30% live with compromised status after operation, a fact which is not highlighted very well in the reported literature. This is the first case which we managed in 1996. This was a 3-week-old who presented with intestinal obstruction and a mass on the abdomen which has a well-formed lips, nose, and lip, and a stoma opening at the umbilicus, draining bile. This was the same time when Dr. Naeem had separated successfully conjoined twin in Islamabad. We delineated the anatomy with X-ray, CT scan, and contrast study, and operated as patient was presented as an emergency with intestinal obstruction. The whole mass was filled with the liver, which was attached to the right lobe of liver of the baby. Those days, liver resection was performed by finger fracture technique. The other techniques were not described in the literature or surgeons were not familiar with. So we had a blood loss, 50 cc blood loss in a neonate is not looked at appropriately. So patient had a stormy post-op course but survived. And this piece of intestine was attached to the duodenum. It was actually a duplicated duodenum, which we incised and later reconstruct the abdominal wall. Mind you, this resection of this extra liver was necessary to close the abdomen in these patients. That was the time when all the meshes and the material which we used to close the abdomen was not available to us. The second case was next year. This was a 1.5-year-old female who has presented primarily with anorectal malformation, with the stool coming from anovestibular fistula. There was an extra pelvis attached at the back. This is one buttock and the other buttock. Main rectum was in this ending in the extra pelvis, and the fistula was opening here. So, by those days standard, we performed CT scan, contrast study, and labeled it anorectal malformation, rectovestibular fistula, performed posterior sagittal anorectoplasty with relocation of sphincter from the accessory twin. And covered it with a colostomy, as was the norm those days, removed the extra pelvis and it made a good recovery. My purpose of presenting these parasitic twins, or heterophagus, we call it, is these, when these patients present, they give you an opportunity to investigate, evaluate, and learn few surgical techniques which may be useful when a real case of conjoined twin present to you for separation. Then in 98, we had NICH twins. They were trochophagous, similar to the case which Zafar recently posted on the group. And that reminds me of those days. So we investigated him. On ECG, he has a single QRS complex, means heart for joint. Echocardiogram, those days, was a very difficult investigation to get. The only pediatric cardiologist in the large city of Karachi, Professor Nazir, and not easy. And so was the CT scan with the contrast, because these patients need general anesthesia, and that was not easy in a patient who has a congenital heart disease. So patient has a complex cardiac anomaly, 6-chamber heart, pulmonary artery stenosis, tetralogy of Fallot, and extracardiac shunt, has shared liver and probably also GI. So this case provided us an opportunity to evaluate a case of conjoined twin thoroughly and generate a discussion in the hospital how to manage these patients. So the decision after a long discussion, evaluation was not to operate. Until to date, at that time, pediatric cardiac surgery did not exist. And our children used to cross the border to get their simple cardiac defect repaired. And as I mentioned, one pediatric cardiologist in the town. So we decided not to operate on this child. Until to date, children trochophagous with such a kind of abnormality, there have been no success in separating these conjoined twins. Although there have been few attempts, but they did not survive. And we have to wait for a long time to have our next case. This was trochoamphalophagous, joint from the nipples to the umbilicus, long union with the joint liver, 2 hearts with 1 pericardium, and the demarcation between 2 sides of the liver was very clear. So in a way, simple case, but it was first for us, so generated a lot of anxiety, excitement, and all those things which are with these cases. So patient also had a congenital heart disease, Pinkhoff. The separation surgery was performed at 5 months. Team approach, about 50 healthcare workers, including doctor, participated in this operation. The hallmark of this exercise was to do a dry run, which I will explain to you in a while. Dry run a day before the surgery, means erecting the operations as we will do it the next day. We used minicons, set the OR, arrange the IVs, everything as it would be in a real operation. And this dry run, I was impressed with the enthusiasm And this dry run was performed on a Sunday morning. Everyone came, every team member came and participated, contributed. Our anesthesia team, they give innovative anesthesia. They have learned from the previous case about 14 years ago. So they gave anesthesia and radiology and the OR, and I think is the reason for success in the case. And we also learned how to resect livers. And at that time, we thought, could we reduce this blood loss? So we used an innovative technique in this case to separate the livers. So this we reported. Yang from China in 2010, impressed with the hanging maneuver in mid-liver dissections, described the cotton tourniquet technique, which we simplify and have reported and applied to the next two patients very successfully. What is this technique? After the liver is at a separation stage, we pass two Penrose drain on each side of the marked resection, tied it, and divide the liver with a high energy device. Sutures ligated the biliary and vascular, and that was, the blood loss was very minimal. I would say less than 20 cc blood loss in this patient. So another problem which we learned during this, there is a cross circulation between two twins. And the learning point was the euphoria of separation was over in just 2 hours when both patients were in shock. So as I said, we described this rubber tourniquet technique to resect congenital hepatoblastoma in a 3-day-old. We passed a tourniquet, resected, minimal blood loss, and baby made a good recovery. So hemodynamic instability in immediate post-op period because of change in the circulation of each twin. And this is here our PICU and pediatric cardiology and nursing played a role. They had an echocardiogram in the PICU. Diagnosed that this patient has developed pulmonary hypertension, and they guided our intensivists to modify the drug treatment from minute to minute. And that's how babies were out of shock and they were discharged on 12th post-op day. We had a minor derangement in the liver functions which settled spontaneously. The patient with tetralogy of Fallot had a repair a year later, developed a complete heart block for which she required a permanent cardiac pacemaker. Now at 6 years of age, living independently, growth parameter as per normal children, going to school, different personality. This is I would say an extrovert and introvert, and it's obvious from the photograph. And this is our latest patient, done about 3 months ago. They were 8-month-old. Trochomphalophagus joined from the nipples to the umbilicus with a large umbilical hernia. They had shared liver, 2 normal hearts, but in 1 pericardium. Because these patients have now 8-month-old and they will pull each other all the time. So they develop a very severe pectus excavatum. if one sleep, other will slap him. So that was going on day and night. So that this development of practice excavator made the closure difficult. Another high point in this case was this was performed at a peak of COVID pandemic. And that was another challenge in this patient. Similarly, we did imaging in a different way because we had better machines. Our radiologists were better educated. So CT scan, liver union was more marked, and one hepatic vein drains directly into the heart. And the liver union is more marked. This is a 3D reconstruction. Not 3D, what I see, 4C is a 3D printing is now becoming available in, at least in our hospital. They printed the nasal swab used for COVID test. Because in one twin, the gallbladder was not visible, so we have to do new radionuclide study. And a new thing we learned during this study, we quantify the amount of cross circulation between the two limbs, and our cardiologist and pediatric cardiologist and PIC team was prepared for that hemodynamic instability which will develop in these patients after an operation. So the surgery took on total 8 hours, separation of liver, chest, pericardium and abdominal wall reconstruction. That I say was a challenge. But we had a backup now, available material to reconstruct the abdominal wall. Different meshes are available, and that's not an issue. But we were able to close them without using any synthetic material. Early period, as expected, hemodynamic instability, severe inflammatory syndrome, which was managed beautifully by our well-prepared pediatric cardiology and pediatric intensive care. Another thing which happened on third post-op day, patient's bilirubin raised to 8, albumin dropped to 1, and there was derangement in prothrombal time. And this is because of the larger portion of liver we have to transect in this twin. And this we have to manage, just give albumin, all those liver support, and within 5 days patients were out. And on 15 post-op day, this is just before they being discharged. The problem was not over. The patient lived in a community which is father is a mill worker, living conditions not good. People want to come to see these children when they reach their mahalla. So 6 weeks later, one of them came with the vomiting and abdominal distension, dual adhesive obstruction. So had another laparoscopy and successfully discharged home. About 30 days back, the bigger one, he admitted with a seizure to the ER. So we have to run whole workup, and and later found out that patient had epilepsy, which we were not able to pick up before the separation stage, because we thought that they are just slapping each other, crying and slapping each other. They were difficult to diagnose. So when he was put on drugs, this has improved, no seizures. I have talked about this is not a solo flight. Separation of conjoined twins is not a solo flight. It is a teamwork. And you have to, when you have such a problem at your hospital, you have to construct a team. One is pediatric surgeons, and one of them has to be a leader of that whole team, and one coordinator, very important to organize meetings, keeping records, everything in order. So our chief resident played, Aisha did excellent job in coordinating with all the components of the team. Anesthesia, very important. 3 anesthetists, 2 are in action and 3rd watching, sitting on their back and coordinating. And drug management is a challenge when you are giving anesthesia to these children. They're helped by residents and technicians, OR, scrubs, circulators, and one OR coordinator who is there to control traffic and to give you supplies what is needed during the operation. I have highlighted the role of pediatric cardiology, radiology, intensive care nurses in this. Other components of hospital are also important. Security to safeguard the children, especially these days when mobile camera is in every hand and these children start getting extensive photo traffic. The marketing, public affairs, audiovisual, PBSP and welfare, most of these children are from a segment of society who could not afford the treatment. So you need to arrange resources for these patients to enable you to perform such an operation. In fact, whole hospital is involved, from top to bottom, and everyone is interested that such a case is going on, and that is the reason for anxiety and the excitement associated with such an operation. So this team is what this team does. They participate in evaluation. The 2 most important evaluations are imaging and cardiology, as I have highlighted in the cases which I have just presented. How to prepare the team. It is important to keep the team, such a large team, on one page. And that can only be done by sharing information through series of meetings, emails, and informally. It is important to define the role of each member in the team to prevent quests. Seek candid input from members to plan the procedure. That's very important. Prepare OR organized medicine supplies so they are timely available. Dry run, as I have explained, we found it's very useful a day before the operation. It helps to charge the team, organize it, and overcome excitement and anxiety. And redefine, sometimes you have to redefine the role of some team members. And don't forget the consent, ethical issues, if any, and protection of children and family during this. Certainly, I feel perhaps we have a simpler, not a very complex case. I feel it's not difficult. It is a combination of procedures which we do on every day and night. So I feel technically it's not a very demanding procedure. But be ready to innovate and deal with surprises. Not everything is shown on the imaging and evaluation, which you have already done before wheeling such a case to the OR. Post-operative care by the team is important. It does not mean you operate and hand over these cases to be looked after by another. You have to be on the center stage to look after these children after such a surgery. There are difficult times. You need to stand with your team to overcome the difficulties. Next slide. Right conclusion slide. Yeah. Conclusion. Separation of conjoined twin is a unique clinical, surgical, and educational experience, I believe. It's an opportunity to promote a much-needed team and quality culture in the hospital. Dry run a day before surgery helps to narrow the gaps in the team, logistics, and environment. A well-planned procedure is a key to success. The rubber tourniquet technique is simple, effective, safe in separation of liver with minimal blood loss and can be extended to some of the liver resection done for other reasons, like tumors, as I have shown you. Delay in surgery, although is recommended, but it should not be delayed to a long period that can lead to complicate the issue, judgment of chest normality because twins start pulling at each other. The long-term follow-up is important. Only then you can plan better for the next visit. So that's what I wanted to say. This is the day we say goodbye to Ayan and Aman from the hospital. And same day, one of these trees have two flowers on it. Perhaps nature was also celebrating with us. And 2 days ago, they had celebrated the first birthday. I could not come to the inauguration ceremony. Just want to attend their birthday. Thank you.